We're looking at genetic tests. What genetic tests do you think really have a mainstay now? And how would you apply them? How would you find a person at risk who needs to be screened, and how would you apply those genetic tests to those people to either avoid a biopsy or say, nope, this person really needs a biopsy?
Genetic testing, we're basically at the tip of the iceberg right now, where we're starting to incorporate that in everyday practice. And genetic testing, whether it's germline testing, mutations that you're born with, or mutations within the tumor itself, are starting to direct how we treat patients. And just this past year, we've had 2 drugs approved based on a patient's mutation status or their genomic profile. So I think it's very exciting, and the field is moving very rapidly. And I think it's important. So not only can we target which therapies to use, but also we can decide on which patients need to be treated and not be treated, and you talked about PSA and Gleason score, and that's basically 1990s urology, and we need to move past that. We need to move to where lung cancer is, where breast cancer is, and use the genetic signature or the genetic profile of these cancers to decide how to best treat these patients.
That's great. And I think that that's really an important statement, because breast cancer therapy has quite a lead on us. They've been very fortunate because of the amount of energy, research, dollars that have been committed to breast cancer. They took a lead in looking at genetic risk factors, and there's no question that BRCA genes became very much popularized in the last 5 to 10 years with great spokespeople, people like Angelina Jolie and others who've actually spoken out about being BRCA gene positive and what impact that's had on them, and how they've applied it to their own personal health.